Okay, my name is David Wilder, and I've changed the title of my talk somewhat from the program. It's now called, I hope you don't mind, it's a simpler title, Recent Research on Improving Staff Performance in Human Service Settings. And I'll start off by thanking some people who helped me in this and some of the data I'm going to show. First person, Sarah Cassell, who's standing over there. Byron Ryan is not here, and Elizabeth Avalon is not here. Kristen Myers is also here somewhere. So thank you to all. There's some other graduate students that I need to thank, but I just didn't have time and room. So these are the major contributors. I'm going to talk in my 30-minute time frame about two topics, and they're somewhat unrelated. So I'm going to try and make it clear when I switch to the second topic so that you can follow me a bit. But basically, I'm a faculty member at Florida Tech, and I do research in a number of areas, and these are two areas that I've become interested in. And so I'm going to give you an idea of the background of these areas and show you a little bit of data in these areas. First area is research on managerial identification of preferred items or activities that staff might be willing to look for. And again, I'll talk in more detail about that in a second. And the second is recent research on the manipulation of response effort to improve staff performance. So first off, identifying items for use in performance improvement programs. So as many of you know, behavior analysts have a good technology for identifying items and activities that clients that we work with, often folks with developmental disabilities, many of whom who have poor language skills, we have good technology for identifying items and activities for them. We've developed a number of procedures that have been shown to be very effective for identifying these things. There's been less research, though, on items that have been identified for staff that are working in our human service settings. In many cases, we were talking in the earlier session about using items and activities to reinforce staff's performance. So the issue becomes, how do you identify those items? Once you do identify them, what's the best time frame to deliver them on, and etc. There's been very little research in that whole area. Even before you get that far, the question becomes, you might ask, does a manager or a supervisor, is he or she able to accurately identify what items that a staff or employee might work for, or do you have to go to the staff or employee him or herself? Some of you may remember there's a while ago in the preference assessment literature, there was some work on, well, can we just ask our clients what they might be willing to look for, those who can actually tell us what they might be willing to look for, or should we ask staff to, or should we identify what they might be willing to work for objectively in the form of a formal preference assessment? So really there's been no, as far as I'm aware, up until the last few years, research on whether or not we could ask staff directly, we had to ask staff directly what they would be willing to work for in the context of this, or if we could go to managers and supervisors and say, hey, you know so-and-so, what would they be willing to earn if we put a performance improvement plan in place? The first research that relates to this was done by Carolyn Green and her group and Denny Reed in the late 80s. Some of you may remember this study, they assessed correspondence between staff prediction of preference and actual client or student preference. So this was working with a client or student and staff. This research kind of prompted a lot of other research on preference assessment. Essentially, they showed that it's not good. You can't just go to clients, to staff, and say, what do you think your client so-and-so would be willing to earn or work for if we were to use something to teach him or her a skill, or use something to reduce some behavior, use an item or reinforcer to reduce some behavior. So it was a very creative study, ingenious. They asked the staff member to nominate some items, and they got those same items and tested them in a formal preference assessment, a paired assessment with the actual clients. And then they had two sets of items. They then did a reinforcer assessment to see with all the items, to see which ones actually increased behavior, and then compared the two results. Compared the staff identified with the client-generated items, and found that there was no comparison. That the items that staff identified were, for the most part, did not function as reinforcers. The items that were identified in the formal preference assessment did function as reinforcers. So the conclusion was that you can't just ask staff and caregivers. You need to formally assess preference. This was later replicated by the same group, Carolyn Green and Denny Reed's group. So 2 studies found the same thing. So we got interested in this and did a study a few years ago, published in JOVM, in which we asked managers in a variety of settings to predict what items and activities that their staff might be willing to work for. So we're kind of taking that relationship up one level, right? So instead of caregiver, client, we're talking about now manager, staff member. And so client would be the 3rd level. We're not focusing on that client level for now. The settings included many human service settings, but also some non-human service settings. We looked at the relationship, simply asked managers to identify things that they thought their staff would be willing to work for, then asked the staff themselves, and then just did some correlation coefficients. No reinforcer assessment was involved. But we found that the mean correlation was very low, 0.11. If you remember, any of you remember correlation coefficients, you know that they can go from -1 to 1. 0 is no relationship. So this was 0.11, very close to no relationship between what the manager said and what the staff actually said. We replicated this study with over 100 participants. This study's in the press in JOVM. And in the first one, we only had about 25 or so. And in this second study, we included many human service settings, a large, wide variety of human service settings, group homes, early intervention centers, etc. And again, found that the correlation was a bit higher, but still very poor, 0.25. And that only 36% of managers could accurately predict their employees' number 1 most preferred item. So essentially what that is telling us now with these 2 studies is that you can't ask a manager or supervisor, if you're trying to set up a performance improvement program, even though it would be very efficient and easy just to go directly to the manager or supervisor and say, what can we use? What 1 thing or maybe what 2 things can we use? Or if you want to individualize it, what can you use for each person, each staff member on your team? That would be nice to do, but it doesn't look like that's the case. You have to go to each individual staff member to get accurate data. So, as I said, bottom line is that managers aren't very good at predicting what staff would like to work for. If they're setting up a performance improvement program, you go directly to them. There's other questions centered around these issues or related to these issues, such as does staff preference for items and activities change over time, and how often should preference be assessed if it does change over time? That I have some data on, but I'm not going to talk about that. A graduate student, Kristen Myers, actually later this afternoon will present some data that's related to this. But for now, I'm going to move on to the second topic that I mentioned earlier. This is an important area, though, because, like I said, no work's been done on it, and it's something that was mentioned in the previous, this morning in one session, I think, that is, we need, if we're going to improve staff performance, we need things that will function as reinforcers for staff, right? And we can't always use money. It's too expensive and it's not very practical. So what else can we use? How do we identify those items? What's the time frame on which we need to assess staff preference for things, etc. So my second topic is reducing response effort to improve staff performance in human service settings. And I've got a couple of studies I'll show you some data on from these. So you all know, everybody in here knows that there's really the 2 pillars of intervention in OBM and human services in particular are training, number 1, and then feedback. There's been many studies showing that training is an effective and in many cases necessary component of intervention to improve staff performance, right? I've cited just a few here. The same goes with feedback. Dr. Miltenberger spoke earlier about how important feedback is, and talked about the activity that hasn't been looked at. There's in both JAVA, JOVM, and a number of other behavioral journals, there's been many studies published showing that feedback is necessary, and it is often effective in improving performance. So those 2 are solid interventions in OBM and human services. Another, though, intervention that hasn't been looked at too much, and although Lynn this morning mentioned one study that she had, I think in one phase that assessed this, but really not much has been published on this intervention, is effort, manipulation response effort. So in their, Pat Fryman and Al Poling in '95 wrote an article, a review article about effort and its use in all applied settings, not just as an OBM intervention, but also as a clinical intervention, review the literature in that area. And basically came to the conclusion that this is an underutilized intervention, that we as behavior analysts often think of more other interventions like training and feedback in OBM and other interventions in clinical areas to use before we'll nominate response effort or use response effort, and suggested that we think of this more often and use it more often. So it's defined as the amount of effort a person must put forth to successfully complete a specific behavior. And there's, as I said, there's not much research on the manipulation of effort to increase performance in human service settings. Actually, there's, as far as I know, there's none. I didn't realize that Lynn had some, but this is, there's been some in clinical settings. There's been some in non-human service settings, but not much, maybe 1 or 2 studies. So it's something that is in need of investigation. So I'll show you some data first. The first set of data I'll show you was published in JAVA, not this issue, but the previous issue in the winter. And then the second set of data, I only have preliminary data, but I'll show you what I have so far. In the first data set, we had 3 staff at a university-affiliated autism treatment center. It's the Scott Center, which is part of Florida Tech. It's a fairly new, about a 1.5-year old building, 20,000 square foot building, where we provide services to children and families who have autism. We have an early intervention program and a severe behavior program, as well as a few other programs. In this study, our dependent variable, we have 3: glove wearing, hand sanitizing, and electrical outlet replacement. And this morning, some of Siggy's and Lynn's group mentioned the importance of hand sanitizing, washing hands. I'll get into more about that in a second. That is a big issue in human service settings, is disease prevention. So that's one of the reasons we focused on this as a measure. Wearing gloves first, though, just to give you an idea of why this is important. The CDC recommends universal health precautions in healthcare and human service settings. Due to inadequate barrier protection, about 2 million people a year become infected by diseases. And in the last couple of years, there's been more talk about this with the H1N1 virus and other diseases that can be transmitted via blood and other bodily fluids. The second DB we had was hand sanitizing and hand washing. The CDC recommends using hand sanitizers or washing hands after contact with clients. This doesn't happen much, especially in settings that we work in. We often prompt our clinicians, direct care staff to wash their hands, but it doesn't occur much. There's actually some data on how often it occurs. This was at a hospital in Switzerland, I believe. They have about a 50% compliance rate with hand washing. And by the way, this has become a really big issue in hospital settings, not so much human service settings, but in mainstream general hospital settings, it's become a really big issue. This morning, if you saw Dr. Bailey's talk, he flashed up a picture of the Checklist Manifesto, which is a book that's actually by a surgeon. And the surgeon wrote the book based on an intervention that he put in place in his hospital. And the intervention was essentially a checklist for washing your hands before you interact with the patient. And not only, he has all kinds of data on how effective this checklist was to increase hygiene protocols in different areas of the hospital. So in surgery, for example, they improved patient outcomes by, I don't know how much, but a large amount, simply by putting the checklist in place and making sure that nurses and physicians were washing their hands and using proper hygiene. So it's a big issue. Another issue that you might not know is important, especially in early childhood settings serving children, is electrical outlet cover replacement. There are actually a number of fires, many fires, thousands of fires each year, resulting in something being put in electrical outlets, and many kids are often hospitalized each year because they're sticking their fingers or toes into electrical outlets when they're not supposed to. This is just a picture of those of you who haven't seen it, Scott Center for Autism Treatment on the Florida Tech campus. This is where the study was conducted. So we define glove wearing as putting gloves on at the appropriate times while in the facility. We have a fairly strict policy about when the gloves should be worn. So they should be worn before and after all client contact. So, of course, when toileting, during the toileting when it's going on, after toileting, when another activity, the therapist moves on to another activity with the client, Anytime a therapist moves from working with one child to another child, a new pair of gloves should be worn. So there's actually 6, I don't have time to go into detail, but there's 6 specific times during which a therapist is supposed to be wearing gloves. There's a specific definition of how the gloves are supposed to be put on and what constitutes correct glove wearing, just a picture of that. Hand sanitizing was defined as using the available bottle of sanitizer to sanitize hands. There are specific times when this is supposed to be done. Toileting is one of them. Feeding is another. There are hand sanitizers located across the building now. And electrical outlet replacement was a third, and was just defined as placing those plastic protectors on the outlets at the appropriate times. So here's just a picture of one of the therapy rooms with an outlet that doesn't contain the plastic protector. We manipulated effort for all of these, and for gloves and for outlet covers, the aspect of effort we manipulated was proximity. That's how close the item was to the therapist. And then for hand sanitizers, we manipulated actually the force required to press down the plunger to get the liquid. And so we wanted to see if that simple manipulation would affect how often therapists used the hand sanitizer. So specifically, for glove wearing, we had 3 conditions: a low condition, medium condition, and a high condition. The low condition was the gloves were within 2 feet of the participant. The medium condition, the gloves were within 10 feet. And the high condition, the gloves were within 20 feet of the participant. 2 conditions for the hand sanitizer. Remember, this was the degree of difficulty of the plunger, to press the plunger, so not proximity here. So we had a low effort condition and a high effort condition. And then an electric outlet replacement, we had 2 conditions, and that again was proximity, low and high. Within 2 feet was low, and within 10 feet was high. And we evaluated this manipulation with multi-element design. So here are the data for glove wearing. Sessions are on the X, percentage of safe performance is on the Y. These are group data, and I'll show you individual data in a second, but I wanted to show you the group first. The high effort condition is at the bottom, the filled triangles. The medium effort conditions in the middle, the filled squares, and the low effort conditions at the top here with open circles. So as you can see, the glove wearing didn't occur much in the high effort condition, right? So sessions on the X, percentage of safe performance over here, they're 0, so glove wearing rarely occurred. It occurred more often during the low and medium effort conditions, and it occurred most often during the low effort condition. It's not where we'd like it to be, even in the low effort condition, but it's substantially higher. Both of these conditions are substantially higher than the high effort, and even the low effort is higher than the medium effort. It's a practical difference. These are the data for hand sanitizing. Again, sessions are on the X, percentage of safe performance on the Y. Low effort conditions, open circles, and then the high effort conditions, the triangle. You can see we got some difference here, nowhere near 100% like we'd like to see it, but the low effort condition produced more performance than the high effort condition for this one as well. These are the data for the outlet replacement, sessions on the X, safe performance on the Y. Not much differentiation, but we never had any replacement during the high effort condition. We had some during the low effort condition, but it was variable. Some days, therapists did it all, every opportunity that they had, every time they were supposed to do it, they did. Other days, it occasionally occurred. In many cases, it never occurred. Here's the, I have individual data for 3 therapists, so this is the first, Meg. These are the 3 DVs: glove wearing, hand sanitizing, and outlet replacement. So what you might expect to see is something like we see here, where much more opportunities for doing each of these things are seen in the low effort conditions relative to the medium, relative to the high. So for Meg, that's what we saw for glove wearing. For some of these, the therapist didn't have an opportunity to perform them, or not enough opportunities to perform them, so I didn't include data. But certainly for the glove wearing, on an individual basis, she exhibited more. She did more often when the effort was low than when it was higher. These are the data for the second therapist, Allie. Again, same sort of pattern. one exception here for glove wearing, she had an increase, actually had more glove wearing during the medium effort condition than the low effort condition. But for the most part, we see that same pattern where less effort means more responding. These are the data for Sally, the third therapist. Same pattern, less effort, more responding. So in general, when the response effort requirements increases, safe performance decreases. And when response efforts decrease, safe performance increases, like you might expect. We also had a social validity measure, and essentially we just asked the participants which of the 3 effort conditions they would prefer, and as you might expect, they all chose the low effort conditions. Essentially, if they didn't have to work, that's what they liked. They preferred not working and not putting in much effort. We now have, we started a second study on this topic, so I'll quickly go through this and show you some preliminary data that we have. The purpose of this was to assess reduced effort requirement on performance, and if it's ineffective, to evaluate the addition of other intervention components. You saw in the previous study that even though we got performance up in the low effort condition, as I said, it wasn't at 100%. Right? There was still a lot of room for improvement. And actually, practically, we had to drop in feedback. I can show you the feedback data, but to get performance up to a level, practical level, we dropped in feedback on top of the effort. But we wanted to formally evaluate that in the second study, evaluate effort, and see what we could add to, if needed, to increase it further. So, same setting. In this case, we had 6 staff members, but it was at the Scott Center, the Ford Tech campus, and it's being conducted now. Our DV for this study is percentage of opportunities in which staff sanitize a client workspace after the client consumes food. So all the clients eat snacks and lunch, or many of them eat snacks and lunch at the center, and that same space that they eat at is also used for work. So it needs to be sanitized after the clients eat, and it's often not being done. Therapists will just immediately go after eating and have the other clients just start working. So there have been some problems with that. We have 3 independent variables. Effort, manipulation, in this case it's proximity. The equipment that they're working with in the work area needs to be sanitized and is placed within equipment needed to sanitize the area needs to be placed within 1 foot of the work area. And then we've got effort plus a visual prompt, and then effort plus a prompt plus feedback. We haven't made it that far yet. The design is a multi-baseline across participants. And here are the preliminary data. So sessions are on the X, percentage of sanitizing is on the Y. I'm showing you data for 3 participants, Sammy, Nan, and Ricky. So far with Sammy, this is baseline phase here. This is the reduced effort here in the form of proximity. And here we've got the second intervention, reduced effort plus visual prompt, and we haven't made it to the third yet. So you can see for Sammy, the reduced effort, that is increased proximity alone, was effective to increase performance for him. And these are across multiple therapists. So I'm showing you data according to client for multiple therapists. I have data on individual clients too, but I don't have time to show it. And maintenance probe there from Staples as well. It didn't work. The same intervention, reduced effort, did not work at all with our second client, Nan. And so we've implemented reduced effort plus a visual prompt. That also hasn't worked yet. So we're probably going to have to go to the third level. We haven't progressed very far with Ricky. He's still in baseline. So it looks like for some staff, effort manipulations are sufficient to get performance up, but it's not likely to be effective in and of itself. Additional intervention components might be necessary. Nevertheless, I think that in addition to training and feedback, that efforts, as I said earlier, is an intervention that's often overlooked in human sort of settings, organizational intervention that's often overlooked. We should probably look into more, apply more, if for no other reason that it's really simple. It's very easy. I think earlier Lynn mentioned that their effort manipulation involved having the therapist have sanitizer on each therapist's person, and it unfortunately didn't look to be very effective in their study, and we got semi-effective results in our study, but it's something that might be added to the training and feedback interventions to get things up in these sorts of settings. So thank you.